Should probably get started since it's 7 a.m. Good morning, everyone, and welcome. My name is Jose Flores, and I am with Project Echo. Thank you for joining us for this exciting session with Dr. Jay Butler, Alaska's former Commissioner of Health and Social Services and Chief Medical Officer, and is currently the Center for Disease Control and Prevention's Deputy Director for Infectious Diseases. Dr. Butler will address Alaska's medical providers and healthcare stakeholders about the implications of the COVID-19 vaccine in Alaska. He will be providing an update on the vaccine development, distribution, and clinical use. Also joining us today is our current State of Alaska Chief Medical Officer, Dr. Ann Zink, and representatives from the Alaska COVID-19 Vaccine Task Force. We will begin with a brief introduction of our panelists, followed with an opening statement by Dr. Zink, continuing with a presentation by Dr. Butler, and ending with a Q&A. We have a list of questions that were pre-submitted through the registration form. However, if you do have any questions, please enter them into the Q&A feature, and our panelists will try to address as many questions as possible. Panelists, as I introduce you, please state your name, role, and organization. Thank you. We'll begin with Dr. Zink.
Morning, everyone. Dr. Ann Zink, Chief Medical Officer for the State of Alaska. Thanks for tuning in.
Thank you. Dr. Butler.
Hey, good morning, everyone. Jay Butler, Deputy Director for Infectious Diseases at the Centers for Disease Control and Prevention.
Thank you. Tessa Walker-Linderan.
Good morning. I'm a nurse consultant with the Division of Public Health and the co-lead for the Alaska COVID Vaccine Task Force.
Thank you, Tessa. Kelsey Pistone.
Good morning. I'm the CDC Public Health Advisor that's assigned to the Alaska Immunization Program, and I'm on the Vaccine Task Force and the Software Solutions team.
Thank you, Kelsey. Regina McConkey.
Hi, I'm Regina McConkey. I am on the Vaccine Task Force, State of Alaska employee, and I am supporting communications and education.
Thank you. And Sandra Leclerc.
Good morning, everyone. This is Sandra Leclerc. I'm the Section Chief for Rural and Community Health Systems and the Deputy Lead for the Alaska Vaccine Task Force.
Thank you, Sandra. And Matthew Bobo has joined as well. Matthew?
Good morning.
Good morning. Would you like to introduce yourself?
Hi, I'm Matthew Bobo. I am the Immunization Program Manager with the Section of Epidemiology.
Thank you, Matt. Wonderful. Thank you, everyone, and welcome. Dr. Zink, I'll hand it over to you now. Thank you.
Great. Good morning, everyone. Thanks for joining. We talked about doing wine and cheese with Jay, but the schedule worked out better to do coffee with Jay. So appreciate everyone getting up and coming in. Dr. Jay Butler is not only my predecessor, but mentor and hero in so many ways. He has always been hard on the issues and kind on the problems, or kind on the people, excuse me. Hard on the issues and kind on the people. I'll focus on problems this morning. And so it's a real honor to have him here to talk to Alaskans and Alaska healthcare providers about what we're seeing with vaccine. We have our team here and we will be able to answer questions later or at another venue about some of the really specifics about Alaska vaccine distribution within the state. This time is really to focus to hear from a national perspective about the science and the data and where we're at with vaccines. But we are watching the Q&A box and trying to answer those as well and have your questions from before. So if they don't get answered here, know that we've got lots of other opportunities to help make sure that you as Alaska health providers can see what's going on. But Dr. Jay Butler, to many of you, doesn't need any introduction. His footsteps are huge, and I've been trying to fill them since the moment I stepped into this role. And he has been a friend, a mentor, and a real leader, always with an eye for Alaska, as he's working in this tremendous role as a public servant at the CDC right now in a crazy time, but always keeping us in mind, answering a million texts and questions, sending me moments of zen, and always there for Alaska. So I really appreciate his time and effort. And with that, I will turn it over to Dr. Jay Butler. Thanks.
Great. Thank you, Dr. Zink. So good morning, everyone. It's vaccine and caffeine this morning, and I appreciate everybody getting up. I thought about calling this seminar, Wake Up and Smell the Coffee, and if you can't, you probably better get a COVID test. So what I'd like to do this morning is give an overview of the vaccines that we'll likely be seeing over the next several months. Talk a bit about who receives the first doses. It's entirely possible that vaccine will be available in about 2 weeks. Talk about vaccine safety monitoring, because that's something I think everybody is interested in and also is an important part of vaccine confidence. And then spend a little time addressing unanswered questions. I know many of you have questions that I will not have answers for, So I'm going to go on the offensive and address those right up front. So maybe we can go to the next slide, please. So here's a menu of what will probably be the first 6 vaccines. There are 4 that are currently in phase 3 clinical trials in the United States. And you can see that there's a variety of manufacturers. There are a variety of platforms. The 2 that will probably be first available are mRNA vaccines, which we're not necessarily very familiar with. There are a couple that are viral vector vaccines based on non-replicating viruses, and then a couple protein subunit vaccines. I'll say a little more about the details of mRNA vaccines when we get to that, but I just want to start by pointing out it's December 2nd. I know Dr. Zink has shared what's become, I think, a bit of a folklore of we were climbing a mountain together right after New Year's last year, and my phone rang, and it was Nancy Messonnier giving me an update on the outbreak of pneumonia of unknown etiology in China. And that was less than a year ago. And here we are today talking about a vaccine program for a disease that was not known to exist a year ago against a virus that probably only emerged a little over a year ago. So it's really pretty darn amazing. So let me just walk through some of the highlights of these vaccines. The first one that's manufactured by Moderna. I think if you monitor the medical literature, you probably saw some of the early phase 1/2 data that Lisa Jackson had published. The mRNA 1273, I'm going to call it Moderna because that's much more memorable. It's a vaccine that requires 2 doses, 28 days apart. The studies have focused on adults. Over 30,000 people have been enrolled, and enrollment for that vaccine is complete. The process of getting these vaccines out to the public involves going through FDA emergency use authorization. This is different than licensure, and it's a process that's intended to gain the maximum benefit and to minimize the risks as much as possible, recognizing the urgency in an emergency. And maybe the last time people were most familiar with discussions of EUAs goes back to maybe the last pandemic, although we actually ended up having licensure. But before that, going back to discussions about use of ciprofloxacin or other antimicrobials for chemoprophylaxis of anthrax. The EUA application for the Moderna product went into the FDA on November 30th. The second product is a Pfizer or BioNTech collaborative vaccine. It's an mRNA vaccine, 2 doses, 21 days apart. The study was intentionally enriched to include elderly people, included those up to age 85. It also extended beyond the initial goal of 30,000 participants in order to have a significant number of people who are African American or Hispanic or who have certain underlying illnesses. And I'll say a little more about mRNA vaccines and what we know about those trials in a moment, but let's also talk about what may be further down the line. So the next one is the AstraZeneca vaccine developed at the University of Oxford. It's a viral vector non-replicating vaccine. So this is based on a simian adenovirus. So yeah, if you want to know what does that mean, it was isolated. The virus was isolated from monkey stool. So I've tried to reassure our animal handlers that when the monkeys throw feces at them, it's actually an act of love. But the virus is then altered so that it does not replicate, but it does contain the gene to stimulate production of the spike protein, which is the component of the virus to which the antibody response occurs and which provides protective immunity. And I probably should have started by saying the common denominator in all of these vaccines is that they stimulate production of antibody directed against the spike protein of SARS coronavirus 2. This is also a large trial. The manufacturer has also released some preliminary data on efficacy. It also is interesting in that a component of participants apparently inadvertently received half doses for their first dose of the vaccine and actually had higher levels of efficacy. And so AstraZeneca has announced that they are going to have another trial which is specifically looking at those half doses. It may be the most remarkable serendipity since Alexander Fleming forgot to completely submerge his agar plates in the disinfectants before taking off for a 3-day weekend. The next one is by Janssen. It's a viral vector vaccine. It's based on a human adenovirus 5 platform. The thing that is fascinating about this one is there's at least some preliminary evidence from the phase 1 and 2 trials that a single dose may be adequate. So their trial includes both a 1-dose and 2-dose regimen. The other two things to consider about these vaccines is the logistics. mRNA is a very unstable molecule. And so those vaccines have to be handled at extreme cold temperatures until just before administration. The Pfizer vaccine in particular requires -80 centigrade. That's even cold in Fairbanks. The Moderna vaccine, more like -20, so still ski temperature, and actually is a little more stable after thawing. So that hopefully will help improve the ability to get that vaccine out beyond just major centers that have the ability to store ultra cold vaccines. The viral vectored vaccines can be managed at refrigerator temperatures. So I think these are really going to be the workhorse vaccines down the road. But right now, we don't have a definite timeline for completion of the studies and application for the EUA. We don't have a lot of evidence yet of efficacy or effectiveness. So, but as we look getting into March, April, May, I think these vaccines will be the ones that will really get us past that critical point of making sure that the supply is able to exceed demand. Let's go to the next slide. Just quickly, these are some other vaccines that are in development. The only one I'll mention is the Merck vaccine, which uses a replicating viral vector platform, is the same platform that they used for the Ebola vaccine, which is FDA approved. Next slide. So let's talk about mRNA vaccines. What are they and how do they work? The mRNA in the vaccine is basically directly transcribed by the ribosome to produce spike protein, which then the immune system is able to recognize and develop an immune response against. As I mentioned earlier, mRNA is an unstable molecule. It's deconstructed within the body very quickly, just as all the mRNA that's produced by our bodies is deconstructed every minute that we're alive. mRNA vaccines are different from DNA vaccines. They don't need to enter into the nucleus. So it sort of takes a shortcut around the technology that was developed for DNA vaccines. They're kind of the opposite of persistent environmental contaminants. They last a very short time, and because of that short time, it creates the challenge of the cold chain. An analogy I heard the other day that I really liked is mRNA is like chocolate. It tends to melt fairly easily. The Pfizer vaccine is actually in a nanoparticle to be able to deliver it, and they said that's like the candy coating on an M&M to be able to get it to your mouth before it melts. The studies were all focused on outcomes of PCR positive symptomatic disease, in general beginning about 2 weeks after the second dose. So some of the outline here. Actually, I think it's important to notice the number of cases that occurred among the thousands of enrollees. And it highlights really how Operation Warp Speed has worked and why it is that here, less than 12 months after a virus emerged, we're talking about a vaccine. There were really three things that made that possible. One was the fact that we were able to build on this mRNA technology. This really developed out of the response to the SARS outbreak nearly 20 years ago. It's a way to be able to develop a vaccine without isolation of the virus based on the genetic sequence of the virus. So the sequence of SARS coronavirus 2 was first posted on January 10th. The first doses of these vaccines were administered to human beings in phase 1 trials, barely a little more than 2 months later. So that gives us a big jump start on production. A second issue is related to the finances. The federal government invested billions of dollars in all of the vaccines, particularly the ones on the first page, not necessarily on development, but in production. So they've been pre-purchased. Normally, the process would be you'd have these trials, and then the business people would get together and determine whether or not there's a market, and then decide whether or not to go into mass production. Because the government had already purchased the vaccine on speculation, they were able to proceed then with the production steps. Of course, it's a big gamble, because if the vaccines were not shown to be efficacious, we would have bought really millions of doses of vaccine that would never be administered to anyone. The third area that helped move the ball forward is the whole emergency use authorization. It also helps to fast track some of the review of the data available. It's important to recognize that that is a big process. The FDA does not just accept what the companies say. They actually have to review the data. They do an independent review. And I should add that the CDC's Advisory Committee on Immunization Practices is also reviewing those data as well. Actually, additional thing that really helped us, and although it's kind of a sad one, is that the pandemic is continuing. So there were a number of outcomes that were detected. In the Pfizer trial, there were 170 people with laboratory confirmed COVID-19. 162 were in the placebo group and 8 in the vaccine group. So that translates into a 95% efficacy. And what I think is most amazing and most exciting is it was a very similar efficacy in adults age 65 and older. So one of the take-homes here, I think, is that mRNA vaccine technology may be a real path to future of immunization. If I could get a 94% effective influenza vaccine in elderly adults, I know I would really have something, and we can make an impact on the rates of pneumonia and influenza deaths among older persons in the US. They also looked at severity of illness. There were 10 severe cases, 9 occurred in the placebo group. The other product, the Moderna vaccine, initial analysis of 95 cases, 90 were in the placebo group, 5 in the vaccine group, so almost identical effectiveness. There were 11 severe cases, all were in the placebo group. So all of this was incredibly good news, really much better, I think, than any of us could have hoped. I'd stress 2 caveats, though. The independent review by the FDA is ongoing right now. The other is the trials were designed to detect efficacy against prevention of disease. The AstraZeneca trial is one that is designed to also assess protection against infection. So we know, based on the modeling that's been done here at CDC, that more than half of transmissions occur from people who are asymptomatically infected, And of course, the biggest bugaboo that we ran into in the pandemic response was the fact that SARS coronavirus 2 does not behave like SARS coronavirus 1. In SARS, the peak of infectivity is at the peak of symptomatology. There's little evidence of asymptomatic infection or transmission prior to onset of symptoms. Unfortunately, in the case of COVID, even though it's closely related to its viral sibling, it behaves very differently. Infectiousness begins a couple of days before the onset of symptoms. Peak infectiousness is probably right at the onset of symptoms. And of course, anywhere, it's estimated roughly 40% of infections occur with either no symptoms or symptoms that are so mild that particularly the more stoic among us may not even notice them. Let's move on to the next slide. Sorry, I may need to pick up the pace a little bit here. So let's talk about the process that's going to occur over the next several weeks as we move towards vaccine in the community. So I mentioned the VRBPAC. This is the vaccine-related vaccines and biologic product. Let me try this one more time. Vaccine and Related Biological Products Advisory Committee. One of those names that you say so much you forget what it stands for, which is the group at FDA that reviews the data, and it's an independent group, people who mostly come from academia and some from public health and clinical medicine, who advise the FDA commissioner in terms of either authorization or licensure for vaccines. In the case of the Pfizer vaccine, they will be meeting next week, December 10th and 11th, and will make a decision about recommending EUA to the FDA commissioner. That doesn't mean necessarily it'll happen right away, but it could, so we want to be ready for that. The VRBPAC will then meet again the following week, December 17th and I think it's 18th. And again, we'll go through the same process to develop recommendations for the FDA commissioner. At the same time, the ACIP will be meeting and reviewing the data, but also reviewing the final EUA for any precautions or issues that we want to make sure are aligned. And as you're aware, ACIP are the recommendations that we're more accustomed to using in clinical practice as well as public health to decide exactly how we're going to use vaccines. So ACIP really is the group that is more clinically oriented and looks at how vaccines will be used in the real life of clinical practice. So there's two things that will happen when the FDA, or rather the ACIP reviews the data. One is they'll ask the question is, should any given vaccine, we'll call it vaccine A, be recommended? They'll go through a process of reviewing the data and then issue a recommendation. And then the second question will be, to whom should early allocation of vaccine A be recommended? And they'll go through review of the scientific evidence, the ethical principles related, and then the logistics of implementation and develop a recommendation as well. So a two-step process. Let's go to the next slide. So the overarching objectives of the vaccination program and the way ACIP is approaching this is to ensure safety and effectiveness of COVID-19 vaccines, to be able to reduce the mortality and morbidity of this pandemic disease, to help minimize disruption to society, the economy, including maintaining healthcare capacity. And this is really critical, we recognize, as the healthcare system is really groaning under the incredible burden of the COVID pandemic right now. And I just really want to acknowledge everyone who's been putting in the long hours and putting yourself at risk even to provide care to people with COVID-19. This has been an incredibly hard experience for healthcare providers all across the country. And then finally, to ensure equity in vaccine allocation and distribution. The pandemic has really shown a bright light on health inequities in this country, that some people have less opportunity for a healthy lifestyle than others. I heard someone early on say that the pandemic would level the playing field and that we'd all be in the same boat. But I think that analogy is really false. To use a better Alaska analogy, we're all out at sea in the storm. Some of us have more seaworthy vessels than others. Others are in rowboats without a float coat or a life jacket. So I think maybe something that will come out of the pandemic is we'll really begin to address some of the inequities in health in our country. Let's go to the next slide. I saw a question pop up, so just to clarify, ACIP will be meeting again after the FDA VRBPAC meeting December 11th and 12th, and it will be pretty immediately afterwards, maybe not even before it's over. So this question of allocation, who receives the vaccine first, using those principles and thinking about who is at risk of exposure, who is at risk of severe illness, there's several groups that really emerge. Clearly, the group at greatest risk of exposure as well as critical to societal function are healthcare personnel. There's about 21 million in the United States. That's a subcomponent of a larger group that we'll call essential workers. Now, what does this term mean? This comes from a guideline developed by CISA, which is the Cybersecurity and Infrastructure Security Agency, that has been quite involved working with public health and some of the pre-pandemic planning to identify people whose occupations are critical to being able to maintain societal function. It's a fairly extensive list, but addresses things such as the food supply, the energy supply, and the various things that allow us to continue to function as a society. Now, the groups that are at highest risk of severe illness are older people. On this chart, we show the population of adults aged 65 and older, about 53 million Americans altogether, and persons with high-risk medical conditions that it's variably defined, but more than 100 million Americans. And this Venn diagram, I think, is nice because it recognizes that there are some healthcare providers who are over age 65 and have underlying medical conditions. So next slide. So here's the challenge. This is a notional phase 1 sequence as we think through who gets vaccine. Let's break it into phase 1, phase 2, focused vaccination versus vaccination of anybody who wants to come in and roll up their sleeves. If there's, say, 10 million doses available over per week when the vaccine begins to flow, we really need to break it up in even phase 1 into phase 1A, 1B, 1C, and then ultimately general vaccination of the general public. Let's go to the next slide. So ACIP met actually last week and began sorting through this. And this is something that is continuing to be discussed, but talked about phase 1A for being the focus on healthcare providers and long-term care facility residents. And I'll say a little more about why this is the group that they concluded needs to be first in the line. Second, the essential workers, and then adults with high-risk medical conditions. And again, I stress this is what was proposed at the meeting. But yesterday, ACIP met again and voted that for planning purposes for states and public health agencies, we needed to be ready to implement phase 1A as it's outlined here. Let's go to the next slide. So a little bit of the justification. Why healthcare providers? Critical to conserve capacity to care for patients with and without COVID-19. There was an analysis conducted using the CDC, National Center for Health Statistics, mortality data, looking at deaths in the United States in 2020, there's an increase in the number of deaths that are not associated directly with COVID-19. Probably some of those are actually caused by COVID-19, just as we see some fluctuations in cardiovascular disease during the winter months, presumably driven by influenza. Some of those deaths are likely actually related to COVID-19. Others, though, probably not, and certainly has raised the question about whether or not the limited access to healthcare during the pandemic may be driving that uptick in mortality. But also, healthcare providers get COVID-19, as I know everyone on this call is all too aware. Nationally, we're aware of well more than 250,000 confirmed and reported cases of healthcare providers. I stress the confirmed and reported because not all the cases are reported. And there's also been more than 800 deaths that have occurred among our colleagues, among healthcare providers. Next slide, please. Looking at the impact in long-term care facilities altogether through early November, residents accounted for roughly 6% of cases and nearly 40% of deaths in the United States. Skilled nursing facilities have a total population of about 1.3 million in the US, and there's an additional nearly 1 million that live in assisted living facilities. These are also congregate settings where the vaccines that are somewhat logistically difficult to deliver can be administered more easily than, say, the community dwelling people. Next slide. So this kind of goes through the ethical considerations of the phase 1 prioritization, looking at maximizing benefits and minimizing harms. Recognizing that healthcare personnel are force multipliers, and we really do need to preserve our healthcare capacity. In terms of the principle of promoting justice, healthcare providers in high-risk settings will really be essential also to vaccine distribution. And then mitigating health inequities, healthcare providers really include a broad range of occupations. It includes low-wage earners and racial and minority groups. In fact, when we look at the demographics of the healthcare provider world, it is more female than male, more non-white than white. And so it is a group that actually does represent some of the people who've been impacted by the inequities in this pandemic. Long-term care facility residents, altogether, these numbers are a little different than the one on the other slide, but we're going to round up to 3 million. We know they're at high risk of infection and severe disease, and prevention of severe disease in these individuals may reduce the hospital utilization. So again, maximizing benefit, minimizing harm, and trying to keep the healthcare infrastructure functional. Promoting justice. One of the things that I think has been a success is the Federal Pharmacy Partnership Program, which unfortunately does not really address the needs in Alaska very well. I've said it here, so I'll be glad to say it to you guys also. It's a great East Coast policy, but it's a challenge in the frontier West. So this is the partnership with CVS and Walgreens to be able to provide vaccine in long-term care facilities so that we can have more of a centralized distribution to be able to support those facilities. And a number of states have 100% participation now in their long-term care facilities. And this is going to be the way they go. It will also be able to then reach across the socioeconomic spectrum of people who are in long-term care facilities. Next slide. So I did want to address vaccine safety monitoring. And this is fairly complex because we have a patchwork of systems to monitor vaccine safety, and we really want to build on that foundation. So we have systems that are sponsored by CDC, such as the Vaccine Safety Data Link and the Clinical Immunization Safety Assessment Project, that allows us to really do rapid assessments if there's any kind of safety signal. I should also add that we're working with the National Academies of Science, Engineering, and Medicine to have an independent group that would be able to analyze data from any safety signals that are picked up. And this is actually similar to what we did during the 2009 pandemic. The system that is really kind of most foundational in the US healthcare system is VAERS, the Vaccine Adverse Event Reporting System. It is a passive system, and it depends very heavily on healthcare providers being able to report any adverse events that they observe. The public can report as well, but most of the reports are going to come from healthcare providers. But to try and take that platform of passive surveillance and make it more active, we have a tool called vSafe, which is a smartphone-based active surveillance. And healthcare providers play an important role in that as well. And we have a toolkit for providers that should be coming out sometime in the next few days to be able to provide information to people who receive the vaccine so that they can voluntarily enroll in vSafe if they would like. Next slide. So the way this works, it's not unlike some of the symptom monitoring systems. I have one on my phone 11 a.m. every day. I get a friendly text from CDC asking me if I have any symptoms of COVID-19. And if I don't respond in about an hour, I get another text. And by end of the day, I get another text asking me if I need help. This will not be quite as aggressive as that, but it will be a text message that will check in daily for the first week post-vaccination. And there'll be a web survey 6 weeks post-vaccination as well. Again, let me stress, this is voluntary. This is not mandatory. There will also then be follow-ups at 3 months, 6 months, and 1 year. If an event is reported, it then transfers to the VAERS call center, and a VAERS customer service representative will follow up with the individual to get more details and actually complete the VAERS form, which then goes into the process of analysis at VAERS, which is co-managed by the FDA and CDC. Next slide. So I want to close by talking about some of the outstanding issues or unanswered questions. These are gaps in our knowledge that we want to fill as quickly as possible. One is the effect of vaccination on asymptomatic infection. And this is really crucial because right now we don't know if you're vaccinated. What does that mean in terms of how you use PPE in a healthcare setting? What does that mean in terms of testing? If you develop symptoms of COVID, how does that alter the pre-test probability? And particularly if testing is in short supply, how should we manage that? Assessing travel risk. Do you need to post-exposure quarantine still if you've been vaccinated? Could this potentially open up the long-term care facilities and change visitation policies? All of these are questions that are really driven by this crucial question of whether or not the vaccines will also prevent infection so that transmission can truly be interrupted. A second big unknown, and one it's probably the most pressing question for ACIP, is what to recommend about pregnant women or breastfeeding mothers. We know that there is evidence of increased risk of severe illness among pregnant women and also preterm birth caused by COVID-19 disease. 75% of the healthcare population is female, and it's estimated that up to 1/3 could be pregnant or postpartum while providing care. Third area is management of febrile reactions to vaccination. Some of the data from the phase 1 and phase 2 trials suggest that the mRNA vaccines are fairly reactogenic. The data that has been described by the pharmaceutical companies regarding true safety problems are reassuring, but that is job one for the VRBPAC in reviewing those data independently to make sure that indeed these vaccines are safe. They do cause a sore arm. They do cause low-grade fever. They can cause headache and fatigue. And in some of the trials, the prevalence of those side effects are as high as 40%. So it raises questions about how do you differentiate a healthcare provider who has a fever of 100.5 2 days after receiving the second dose of vaccine and saying with confidence that it's not COVID-19 disease and they need to go home, be tested, go home and be isolated. And then finally, the unknown is vaccination of persons previously infected and what is the duration of immunity, whether it's from natural infection or from the vaccine. I get this question a lot about the long-term protection after infection. And it always makes me laugh a little bit because we're talking about an infection that's only occurred in this country for about 9 months now. So we really don't know the answer to that question. Next slide, please. There are a little bit of data emerging on the risk of reinfection. I think I'll summarize this for the sake of time by saying that reinfection with SARS coronavirus 2 does occur, but what we don't know is whether or not it's a rare event or a common event. Next slide, please. The more distant cousin coronaviruses, sometimes called the common coronaviruses that cause common cold-like symptoms, we know infect adults repeatedly throughout life. This is just some data from a cohort of men who have been followed in Amsterdam over the past more than 30 years now. They undergo serial blood collection, and basically what they showed is that reinfections with the common coronaviruses are indeed common over a period of a number of years. 3 to 17 of these infections occurred per person. Next slide. So finally, I want to say that the community mitigation efforts that and tools that we have in the toolbox right now and that increasingly are being shown to work, such as masking, social distancing, and hand hygiene, will continue to need to be used even as we move into 2021. And we have an additional and probably most powerful tool in our toolbox, that of being able to provide immunization. And then the final slide is just a reference to the CDC website. There is quite a bit of information there, and I think new information is showing up every day. And this is a new website, just went live over the past couple of weeks. I hope that it's helpful. It's designed parts for the general public, other parts for clinicians, and I'd appreciate your visiting it and seeing if it answers your questions. If it doesn't, I'd be interested in hearing how we can make it better. I can say for sure that it's not very pretty, but we're still working on that as well. So how about I stop at this point, and I know Dr. Zink and I would love to take your questions. And I see
Awesome.
at least 64 of them down there. No, it's 52 question and answers and 64 chats.
With a couple hundred pre-submitted. So I think we'll turn it over to Regina, who I think clustered a bunch of them and is monitoring, to go ahead and ask away. Thanks, Regina.
Thanks so much, Dr. Zink and Dr. Butler. So one question, we saw some variation on themes of, here I'll just go ahead and quote one of the askers directly. I am almost sure I want to get the vaccine pending the continuing trials and FDA ruling. I would like to hear your honest opinion about the validity of those who say not to take it. And I just wanted to elaborate on that question a little bit. Dr. Butler, you clearly have a lot of information at your fingertips. And perhaps you can share a little bit about how you'll be making a decision for yourself and what resources will help you make your decision.
Sure, that's a great question and a reasonable one. And I think one that all of us will be considering over the next few months. So in terms of receiving the vaccine, and I would certainly want to be vaccinated ultimately. Where I fit into the priorities is a little more questionable. I actually did sign up to participate in the trials, but was never called. I think I'm really happy to say I was too young. That was part of it. I have no underlying conditions, and also there's a real active outreach in the trials to make sure that it's not just old white guys. So I haven't been able to participate in a trial, but particularly once we've had the independent review of the efficacy and the safety, that will be very helpful in making the decision. Just which vaccine to get, I think that'll depend on what's available when the time comes. Every week, it seems like there's a new media question of the week. The question this week has been, well, when I go to my provider, will I get to choose which vaccine? I don't know the answer to that question. Initially, the supplies are going to be fairly limited, and actually we'll only have two choices, most likely between two mRNA vaccines. I don't think we're going to walk in and the maitre d' is going to say, may I start with a vaccine? We have a wonderful viral vector from the AstraZeneca vineyards today. It's not going to be like that most likely. So it does come down to like many vaccines, that personal cost-benefit analysis. And fortunately, we have in this country the FDA to try and make sure that there's an independent review of vaccines so that we can be confident that they work and they're safe. And also the Advisory Committee on Immunization Practices that really sorts through some of the more nitty-gritty questions about how to administer the vaccines. It, in some ways, maybe a little bit like the questions about receiving any vaccine, which gone on for well over 100 years now, as we think about smallpox vaccination or going back even earlier, variolation, knowing that subcutaneous inoculation with the smallpox virus has a mortality rate of around 1% compared to some 30-35% for actual naturally occurring smallpox. If we go back 200 years, that was the kind of cost-benefit ratio people are trying to consider. Now we're getting, I think we've moved ahead quite a bit, and the cost-benefit might be whether or not there's some rare yet unidentified side effect, or whether or not we think it's worth the risk of having a sore arm and a low-grade fever for a day or two. So we've made a lot of progress, but it does come down ultimately to what I hope would be an informed choice. And for me, that's going to be to get vaccinated when I can.
Thanks so much, Dr. Butler. And Dr. Zink, feel free to chime in if you have anything to add. Otherwise, I can move on to our next question.
Yeah, no, there's so many great questions in the chat box. You know me, I have issues if we can't answer them all, which I know we won't, but we want to make sure we can answer as many as we can. So go for it, Regina.
Great, thanks. So, and I know this was addressed somewhat in your presentation, Dr. Butler, but we did receive a lot of questions about children and pregnant or breastfeeding women and when they'll be able to get vaccinated. Is there anything that you might be able to add or elaborate to regarding the timeline and when it might be expected?
Yeah, for the sake of time, I really don't have anything to add to what I said in the presentation, but I will say that this is a top priority for the ACIP as they consider what that means to the healthcare workforce for the reasons that I outlined in the presentation.
Thanks so much. And I feel that you may have a similar answer for this question, but we did receive a lot of questions about people with autoimmune deficiencies and whether we have any more information about what was learned from clinical trials that can provide insights for these populations.
Yeah, and let me maybe tag a little bit onto the pregnancy and lactating women question. So pregnancy and lactation actually were exclusion criteria from the two trials of the mRNA vaccines. Regarding study of people who are potentially immunocompromised, those are data that we haven't seen the full depth of yet. I do know that some of the trials included people with well-controlled HIV disease. So I think that's more of the information that we'll be getting greater visibility on as we get the EUA and specifically the recommendations from ACIP. I'm sort of making the assumption that most people on this call are familiar with ACIP guidelines, but there's a lot of the detail that's sorted out of recognizing the different types of patients that come into a venue, particularly a clinical practice, who would be receiving any vaccine.
Now, just to build on that, how about like cancer patients, solid organ transplant? Were those excluded, included? There's been a bunch of questions popping up about that.
Yeah, and again, that's where we really need to see the more detailed reports from the trials. I hope people recognize that the Moderna platform was developed by NIH, but generally these trials are performed by pharmaceutical companies. And so that's why we talk about the data that's been released by the companies, but here in the United States, we have independent review that's performed. So there's a lot of those details that there are probably people who could answer that question better than me, but I don't at this time have visibility on that.
And I guess to build on that, there's a lot of questions about communication, about safety, about this has all just gone so fast. What am I gonna, why does it take 7 years typically, or what does that mean versus now this has gone so fast? And like, why didn't we do an mRNA vaccine platform before that was widely distributed? How would you answer that to your patients if they came in and asked you those questions?
Yeah, so in terms of a vaccine that we needed fast, I think this is, tired of using the word unprecedented, but I think that really does apply in this instance. We had a emerging infectious disease that has shown such a capacity to kill so many so fast. And so we have this technology now. It's fairly recent, even though it grew out of some of the preparedness work that was being done in case SARS came back. But we've just not had the opportunity to be able to use this tool in our toolbox. But that's one of the ways we've been able to move forward very quickly, is all we needed was the sequence of the virus. I think back to other new viruses, I bet Tom Hennessy is on somewhere on the call. Let's compare it to Synombre virus that Tom took care of one of the initial patients in Crown Point, New Mexico. That was a virus that was not actually isolated until a couple of months after the disease was identified. We are now able to move much more quickly because of the advancements in biotechnology. The other thing that really has moved things along is the market forces kind of got short-circuited by the federal government stepping in and guaranteeing that the production costs would be covered. It's a big gamble, but at least for the mRNA vaccines, I have to say it's looking like it may be a gamble that's going to pay off.
Super helpful. One last kind of question that I have kind of seen a bunch, and I know Regina's getting a couple more big ones kind of tuned up for you, for kind of healthcare providers who are thinking about this, and they're thinking about, the reaction that they may have. How severe is that? What do they want to be thinking about? How soon will they really think about kind of getting immunity? I know you talked about, the fact that we don't have enough information about masks and stuff afterwards, but when they're thinking about kind of planning, what would you share there?
Yeah, so a couple of things. Let me start with that last question about when you see immunity. Again, the analysis of the data is ongoing, but there is some reports that in the in the interval between the first dose and the second dose, which is fairly short since the outcome clock only starts ticking 2 weeks after that first dose, there is some evidence of minimal effectiveness from one dose. The primary response, based on the antibody response, is going to be best after that booster dose. So how long after the second dose do you really have protection is not entirely known, but I think in general, it's possible that you would have some protection as early as a couple weeks after the first dose. There's a lot of caveats there because just because you have antibody doesn't necessarily mean you're protected. We don't know what a protective level of antibody is. We don't yet know a lot about the functionality of the various types of antibodies that are produced. So I think those are very valid and good questions. We don't have firm answers yet, but I would think in terms of beginning a couple of weeks after the first dose, you're then on the upward climb, particularly if you get the second dose on time, towards having an optimal immune response.
Thank you so much, Dr. Butler. I just wanted to note, we're getting a little close to time here, and I know Tessa Walker-Linderman is going to share some resources. We know we have a lot of questions here that we weren't able to respond to, and so we do have some plans for following up with those as well.
Sure. Thanks, Regina, and thanks, Dr. Butler. I did see some questions people asking about distribution and logistics within Alaska, and I wanted to make sure everyone is aware of our vaccine echo on Thursdays, that we really walk through a lot of just the logistical planning that we're doing. So maybe Jose can put the link to that in the chat, but all are welcome to join that out every Thursday. We also, our website, covidvax.alaska.gov, has quite a bit of information. We really keep it updated with new resources and updated information. We have a section specific for providers and healthcare workers, so definitely check out the resources we have there. And then also in the next week or two, we are starting regional provider calls. These will be in the evening. And we are, we'll get communication out about those, but they will be specific for healthcare providers and just sort of follow on conversations to be able to continue answering these questions. So more to come on that as well.
Great. Dr. Butler, I can't thank you enough for coming this morning and answering questions and taking the time. There are so many in the chat box, and I feel like they are like my never-ending list of questions for you that I'm always hitting you up with as we all are trying to understand the science and data better behind what's happening. For Alaskans awareness, I think of this as kind of like nesting dolls. What happens at the federal level and ACIP and these guidance is kind of this big guidance. And at the state level, we are providing additional guidance. We have an allocation committee. They are meeting actually tomorrow, taking these ACIP guidance, and then that will continue to be refined. And then inside that nesting doll is individual hospitals, communities, and what that looks like. And so these are kind of all fitting together, trying to think mindfully and broadly about everything from healthcare workers in a prison setting to house cleaners to healthcare workers in an occupational setting. All of those things are being discussed and being taken into consideration. As Dr. Butler mentioned, there's the science and data behind it, and there's also the logistics, which are uniquely challenging in this state as our numbers change on a regular basis. I know that the echoes are at a hard time for many people to attend. They all are recorded. We are doing summaries of them as well that are being pushed out, including references to the literature articles that we have, and trying to make that as easy and accessible for you all as you're caring for patients at the same time and trying to find solutions to this. So there's many, many unknowns still, but the fantastic thing is that we've got these partnerships. And so thank you all for tuning in. And thank you, Dr. Butler, for your amazing team, your incredible service to the state and to the country through these challenging times. We are eternally grateful. So with that, I'll hand it over to Jose to close us out and just want to say my appreciation to all of you all.
And I'll just say thanks to all of you for joining us and all that you're doing.
Thank you very much. Thank you everyone for attending today's special echo. Thank you as always to our State of Alaska officials for their time and commitment. And a very special thank you to Dr. Butler for making the time to be here with us today. As always, in our echo box page, you can find today's recording as well as any resources that were shared. The link is in the chat for you. Thank you everyone and be well.